Hello, my name is Carolina Varela. I am a physician at the Quality of Care Unit of the Hospital Universitario 12 de Octubre in Madrid. I am as well member of two scientific societies, the Spanish Society and the Madrileñan Association of Quality of Care. Thanks for watching. It is a pleasure for me to introduce you to this work titled Value-Based Health, Value-Based Culture on a Tertiary Hospital and Responses to COVID-19 Epidemics, Measuring Quality of Life in Patients at Risk of Long COVID. In June 2020, while combating the first wave of SARS-CoV-2 epidemic, healthcare professionals showed concern about the evolution in the long term of COVID-19 recovered patient symptoms. A monographic consultation was created to improve the follow-up after discharge, and the patient with inclusion criteria were given an appointment for a checkup 3 months later. The nursing staff worried about the patient's quality of life and asked the coordinator of value-based healthcare implementations to measure PROM in COVID-19 patients, included in this consultation, and evaluate the improvements. This work details measuring PROM in a high complexity hospital during a health emergency and the results obtained. Since 2018, the hospital, as shown in the upper part of the figure, is immersed on a strategic transformation towards measuring value and give more patient-centered healthcare within the confluence of the evidence-based healthcare paradigms to monitor and improve efficacy of the care, value-based healthcare to monitor and improve the value offered to the patients, and the global framework of total quality management to assure improvement. However, during the first wave of COVID-19, we found ourselves on the chaos and anarchy situation proposed by Stacy on relation to the level of certitude on the knowledge and the level of agreement in the scientific community. It was in this situation that the nurses of the internal medicine department and the pneumology department wanted to measure the quality of life of the COVID patients with not so good evolution of the symptoms, reflecting a small change on the cultural paradigm of our institution, and with the little time they had to do so many things with the patients, they added something else, and we designed and kick off a descriptive observational study in a cohort of 871 COVID-19 patients over 16 years of age, follow-up after hospital discharge by the internal medicine department of the Hospital Universitario 12 de Octubre from June 29, 2020 to June 15, 2021. All the patients were included in the post-COVID consultation program to a closer follow-up. We took as the baseline the first interview conducted during the first month after the diagnosis. We compare it with successive interviews at 3, 6, 9, and 12 months after the baseline interview. Understand well. So it was not when they had the diagnosis and the more flourish clinical COVID, because they were in no condition for answering any questionnaire. This was people that needed hospitalization for taking care of the COVID. But when they already had the diagnosis and before the discharge in the month, with a variation of 1 month, the first interview was done. The nurses from the practice carry out the surveys using 3 modalities: telephone, face-to-face with assistance, or face-to-face without assistance using tablets. Sociodemographic variables such as age and sex were analyzed, and the loss and recovery of health-related quality of life in patients following SARS-CoV-2 infection was measured using patients' health perception with the European Quality of Life 5 Dimensions Eurocool 5 questionnaire that we will keep calling EQ5 from now on, and the self-rated health status thermometer. Absolute and percentage frequency were used to represent the categorical and qualitative variables, and the mean and standard deviation were used for the quantitative variables. The chi-square test and the student t-test were used to analyze differences between variables with 2 categories: a statistical significant differences A difference was considered with values of p minor to 0.05 and the 95% confidence interval for many differences that did not include zero. The analysis was performed with SPSS version of version 26 statistical package. As you can see, the dates is June 2020 to June 2021, and the cohort, the severe COVID-19 patient cohort attended at the Hospital Universitario 12 de Octubre. We had an initial sample of 800, well, sample no, it was the complete cohort of 871 patients. The answer, the first baseline questionnaire, 76 patients, and they end up 1 year follow-up, 226 patients. We measure for these patients CROM and PROM, but we are going to talk about only PROM in this poster. So it's important to understand as a cultural change that the big majority of the PROM were measured by a telephonic phone call. So the nurses were talking directly with the patients and filling up the questionnaire. I know this introduced some biases, but this was one of the first learnings we had with patients with COVID. First of all, we have to contextualize the situation. We weren't talking about long COVID because we didn't know this existed. It was before this was described, and very shortly later, it was described, the long COVID, and we began to talk about this condition. But at this very moment, at the beginning, this didn't exist. And also we were in a very clear isolation situation, so we couldn't make the patients come and fill the questionnaire and have a checkup on them, and we did it by telephone. And you will be asking, well, this is not a problem because it's not patient-reported outcome, it's a clinician after all, because the nurse is asking the question and can affect the response. And as I was saying, this was one of the first and more important learnings of this work, that nurses notice that the patients included in the cohort showed some levels of cognitive impairment and prevented them in several occasions from answering the EQ5 questionnaire, which is a very simple questionnaire. And as I said, we were not talking about long COVID because it hasn't been defined or at this point of time, but we were also talking about all the neuropsychiatric disorders that we have already described in COVID-19. So this was a huge achievement that we didn't publish, but it doesn't matter, that it was important for the care of these patients. So since we noticed that they have these cognitive problems to answer in the quality of life questionnaires, we decided to limit the collection using only the telephonic communication with the nurses. The second important learning was that due to the circumstances, we could not record properly where the change, the second important learning, and I must say, and I'm really sorry about that, we didn't record properly due to the circumstances, were the changes on the care process. Let me explain. As consequence of the responses to the quality of life questionnaire, the nurses decided to talk to the clinicians, to the clinical team, and give them this information, the information gathered by the questionnaire, quality of life questionnaire, for them to discuss possible changes on the care of the patients. Let's say they talk to the patient and they notice that from the last time they ask this questionnaire, they have more pain or more inability to make daily tasks, or they have anxiety. So they could discuss it with the rest of the clinical team and give the patients the possibility to ask for more painkillers or ask for an interconsultation with mental health or come and have a checkup with a medical doctor. So they did, and they changed, they personalized the follow-up. Another surprising learning was that even when we were following the patient for 6 months or 9 months, we noticed a very limited recovery of the quality of life after the discharge. I remember you that we weren't talking that much about long COVID, and we noticed at this point that they weren't recovering as much as other patient did. I show here a dashboard. I think the measurement here is 9 months, and you can see that sorry, it's in Spanish, but you can see that the global, these are the 5 dimensions measured by the EQ5, and this is the global thermometer, and you can see less than 1.1% improvement, or 1 point of improvement in the global health perception at 9 months. And when we analyze this data at 12 months, we realized the recovery was as well limited. There is some selection of the patients because only 226 finished the 12 follow-up months, and it could be that are the patients with less health recovery because the other lose interest on answering the EQ5. However, we did notice a small recovery of the quality of life in these patients. And this is shown here. We didn't see any differences, clear differences between, you see the patient lost was in the baseline 0.45%, and at 12 months we have lost 73.9% of the cohort. Okay. We didn't find differences in the month of follow-up, the number of consultation, the number of consultations, or the patient scores at baseline. Okay. But we did find differences in the automatic score on the global health score. And this is, I think, and I'm going to explain basically this result. As I say, you have all the information available and you can contact me. But what was more super interesting for me was, well, for us, is that we observe a discrepancy between the self-evaluated global health index and the automatically calculated index. Let me explain. So as you can see here, the EQ5 has 5 dimensions and a global score. Okay, so it's anxiety, pain, mobility, self-care, and then we have this global score, which is basically asking the patient, how is your health today? Being 0, the worst health you can think of, and 100%, the best possible health. Okay. And this last score in our IC tool can be calculated using the 5 dimensions. How this questionnaire works is each dimension is ponderated. It has a weight in relation, and it's validated for the Spanish population and for other populations. So it has a different weight depending on what the Spanish population care more about in quality of life. So it gives an automatic answer to this global thermometer of health. But we at least give the patient the possibility to answer themselves the thermometer and give their response. And we observe an important discrepancy. And this discrepancy wasn't there in the baseline. So as you can see in the table, you can see the automatic score baseline 12 versus 12 months. This is the comparison between the global score calculated by the machine and comparing baseline and 12 months, and there is clearly an improvement of 1 point. But when it's the patient answering this score and we compare as well baseline and 12 months, we don't see this difference. I mean, there is a small improvement, but it's not that big. I mean, it's 6.68 to 6.8. The difference between the automatic and the patient versus patient is big and is statistically significant. And when we stratify by number of consultation or months of follow-up, there is no significant difference between better self-perceived health or worse perceived health. But there is a difference when we do this between patients and the machine. Also, it's interesting to see that the baseline was not that different between the patients and the machine. So the score was answered more or less the same, was well calculated for the baseline, but not at 12 months. So as I was explaining, after 1 year from this chart, the patient showed an improvement of 1.04% with a p minus 0.001 when measured by the automatic algorithm, not percent, 1.04 improvement. When measured by the automatic algorithm, while it was significantly lower, 0.12, when reported by the patient. When stratified, as I said, worse versus better perceived quality, there was a significant difference. And just to finish, just comment that in the 226 patients that adhere to the 1 year prompt follow-up and agree to answer a small satisfaction questionnaire, 91.6% thought that the nurse calls were of high or very high quality, 67 felt more or much more accompanied due to this follow-up with the prompt, and 92.34 would recommend the program for sure to a family member or a friend. Well, I really hope this explanation was clear for you. Just to mention that we are at your service. I leave there my contact information. If you feel like giving feedback or asking questions, you can either write to me or leave a comment on the video. There are several people related to this work that would be very happy to answer your questions, including me, of course. In the video description, you have the link with the PDF and of the poster, the abstract sent to the meeting, and some other information. We do appreciate the interest. We are currently working analyzing the rest of the data of the EQ5 questionnaire and the clinical reported outcomes, and hopefully next year we can bring any other results to the meeting. Remember, as Abedis Donamedia used to say, ultimately the secret of quality of love. So thank you very much. Have a lovely day and see you soon.